speaker, Dr. Sangeet MITTAL. He is a very celebrated surgeon, very experienced surgeon. Again, somebody who's won a lot of awards. He'll be talking to us on managing retinal detachments with staphylomas breaks. Sai, can you pull up his video, please?
Thank you, Dr. Anand, for including me into this symposium.
Pleasure.
I've asked to play the video.
Yeah, Sai, please play his video. Yeah.
Type 3 staphylomas are primarily peripapillary staphylomas. These type of staphylomas are commonly associated with retinal breaks and retinal detachment. Breaks usually result from increased antero-posterior traction and weak adherence of retina with RPA due to chorioretinal atrophy. These breaks are difficult to manage as they lie in the staphyloma and laser is not possible around these breaks. Inverted ILM flap technique has been described to close large macular holes and optic nerve head pits. In this video we will demonstrate the use of ILM flap in the management of breaks associated with type 3 staphyloma. First case is a 43-year female who presented with sudden decrease of vision. She was diagnosed to have retinal detachment with optic disc coloboma, peripapillary staphyloma and choroidal coloboma. 25-gauge pars plana vitrectomy was performed. PVD was induced with the help of triamcinolone. PVD induction is done carefully as vitreous is quite adherent to the edges of coloboma. A retinal break was detected at the edge of peripapillary atrophy inferior to the coloboma. A communication between the vitreous and subretinal space was noticed. ILM flap was used to cover the juxtapapillary break. Laser was done around the optic nerve head and the flap was stuffed inside the break. Fluid air exchange followed by gas tamponade was performed. Post-operatively, retina was attached and the patient regained best corrected visual acuity of 6/18. Second case is a 38-year highly myopic male who presented with decrease of vision for 2 weeks. He was diagnosed to have retinal detachment. His best corrected visual acuity was 5/60. 2 breaks were seen at the edge of inferior crescent inside staphyloma and a communication between vitreous cavity and subretinal space was seen. Posterior drainage retinotomy was done to flatten the retina. ILM flap was raised to cover the juxtapapillary breaks. Due to nasal location of breaks, it was not possible. PFCL was used to stabilize the posterior pole and a free ILM flap was used to stuff the retinal break. Second retinal break was also closed using another free ILM flap raised under the PFCL bubble. Fluid air exchange was done and laser was done around breaks. Air was replaced with 12% C3F8 gas. Post-operatively retina was attached and the best corrected visual acuity was 6/9. Next case is 64-year female. She was diagnosed to have recurrent retinal detachment with PVR in left eye. She was high myope with myopic degeneration and scar in the macula. Her vision was perception of light with inaccurate projection of rays. Pre-retinal membranes were removed. Breaks were seen in posterior staphyloma. SRF was drained through posterior breaks and retina was flattened. Free ILM flap was stuffed in the posterior retinal breaks. PFCL was used to stabilize the posterior pole. Relaxing retinectomy was done to release anterior PVR. 360 degrees barrage laser was done and PFCL was exchanged with silicone oil. Laser around the optic nerve head was not done and neither was possible in this eye. Three months post-operatively silicone oil was removed, retina was attached and the best corrected visual acuity improved to counting fingers at 1 foot. These are pre- and post-operative pictures of few other cases managed with same technique. To conclude, it can be said that retinal tears may develop in areas of chorioretinal atrophy associated with colobomas or staphylomas. Free ILM flap may help in closure of such holes, where laser is not possible.
Thank you.
Thank you very much.
Thank you, Sangeet. Terrific surgery. Dr. Shobit, your thoughts?
Yeah, where you had the nasal break, Sangeet, very innovative technique, excellent videos also. But where you had the nasal break, could you have taken a nasal ILM flap and flapped it, a hinge flap?
Sir,
Or is it technically very difficult?
Yeah, it would have been very difficult. When I started the case, I thought I'll be able to cover with this flap, the hinge flap. But unfortunately, I could not reach that area. So then I already had yeah, and so I just freed it and then just stuffed it under the PFCL. PFCL generally stabilizes the posterior pole environment, and you can easily do the
it's always better to peel under PFO.
Yeah.
Any thoughts, Dr. Charles?
Yes, two. One, I thought the surgery was elegant. I thought the video was phenomenal. The only difference is that I would always use brilliant blue, not ICG, because of the known toxicity of ICG. And the only other comment is that I would not make a ring of laser around the optic nerve head because of the risk of nerve fiber layer damage. I would, even though the visual outcomes that you presented were quite good, I would specifically treat an identified tear if I could. But I think the ILM flap is a superb idea.
Because used in the case, it was like very poor contrast. I tried to stain it earlier with the brilliant blue, but could not get a good stain. I used the ICG because it was a very highly myopic eye. There was a lot of myopic degeneration and a scar there. I got a better contrast using the ICG. Earlier cases, I was not sure, so I did the laser around the optic nerve head. But later on, I realized that the laser really does not help in these type of cases. So now I have stopped doing laser around optic nerve head.
Can we have some views from Dr. Pramod Bhende, please?
You're muted.
Dr. Pramod?
Yeah. This is, I think, very elegant and excellent surgery. I mean, not much to add. Basically, the problem, another what we face sometime, what I was have my doubt about, you have a staphylomas where you absolutely no RP choroid, break sitting right there, not really, maybe macular hole, may not be macular hole as such, and where you just cannot get laser reaction. How we would handle type of situation. ILM peeling also is not that easy. They are deep set eyes. Reaching that area post staphylomas base is very, very difficult. Sometimes you just cannot reach. Dr. Steve could add something on it.
I don't have any other additional comments, except that if you put PFO in place, you can often achieve laser that you couldn't achieve before that, simply because of the 1.8 specific gravity pushing the retina against the pigment epithelium.
And
Sangeet, any thoughts?
Yeah, because there's a question also, because what happens sometimes once you put PFO or you want to do fluid erection, you just cannot see a break also. You do not know what to do, where to laser. And you don't want to do excess laser in a papillomacular bundle or a nasal or temporal side.
Absolutely. Yeah, I agree. So there's a question also, how about using tissue glue instead of ILM flap in cases of, these kind of staphylomas breaks? This is from Dr. Ajay Kapoor, Bhatinda.
Dr. Mudit has presented using
Mudit Tyagi has presented.
Using tissue glue for retinal detachment, I think it's a very good idea. Otherwise, if it works, I've not tried it myself. But
Yeah, but what I would add there is tissue glue gives you a temporary holding there till scar forms. Because I think if I remember correctly, he does laser add tissue glue. Tissue glue holds on instead of having a tamponade probably for time being till the laser takes over for a peripheral break. But if you are not having created a atogenic inflammation, tissue glue will not help in this scenario.
Yeah, exactly. That's absolutely right. It's a
If
temporary.
it goes subretinally, it can have some toxicity at the macula. If it goes subretinally in the peripheral space, it does not have an issue. So,
yeah, right. Also about the same issue about the ICG. I mean, I understand that the visibility, it gives you greater visibility, but for the same reasons, because the RP and the choroid is so thin, these eyes will be more at a heightened susceptibility to toxicity. So I think that's one thing we have to kind of balance when you think of ICG. So fantastic talk. Thank you, Sangeet. Fantastic videos.